Now, Bob, you all know, but let me just say a few words about Bob. Bob's official title is the Edgar Berman Professor and Chair at the Department of International Health at Johns Hopkins School of Public Health. But there is almost nothing significant about child health that takes place in the world today without the imprint of Bob Black's hand on it somewhere. He has been and continues to be an incredible international leader in child health and maternal health too. And what Bob does is, and this is so important to do good science, he builds collaborations. It's not about him, and it's not about Johns Hopkins, it's about the collaboration and sustaining the collaboration to bring the best scientists together to do the best possible work that can have the highest impact. I've had the privilege and pleasure of working with Bob now actually for over a decade. And every time we've interacted and worked together, he always delivers. He's delivered this time. Please give a very warm welcome for our leader.
Thank you, Richard, for the very kind introduction. You're right, I can't keep my hands off of things that I think are important, and this is one. So redoing this series, I thought, and fortunately the people I could get to help with it thought was not only important but very timely, and we did pull it together. So what I'd like to talk about is paper 1 of the series. And I show here the authorship of the series, and certainly would like to acknowledge all of the authors of the series that contributed to it. And while I'm at it, and may not have another chance later, to thank the staff of the Lancet, the editorial staff, because they do an enormous amount of work for these series, and we had some excellent editorial assistance to get this together in what was, for them and for us, I'm sure, a pretty unreasonable time frame, but it did come together. As Richard said, we did want to time it around now because we knew of the Nutrition for Growth event that's coming on the 8th in 2 days, and many other activities leading up to the G8 discussions on food security and nutrition. So seize the moment, I guess. We decided this would be the time. So as I'm sure you know, there was a previous series in 2008. That series identified a critical period of the time since conception and to the second birthday. It's called the 1,000 days, in which good nutrition and healthy growth have both immediate and lifelong consequences. That series also called for stronger national programs, more integration of health and nutrition programs, very much asked for better intersectoral and interagency cooperation within the nutrition system. And I think now, 5 years later, in 2013, we have an opportunity to look at what progress has been made, how much of the burden related to undernutrition remains, and what are its consequences, what are new interventions and programs that might address these problems, but also to what extent has there been a movement for change and a better coordination, both national and international. So that would be broadly the content of the series. Just so you know, and it's on your agenda, I won't go into it. There are 4 papers of the series that are now released online in the Lancet, and a comment, as we say, a call to action comment that also appears from the authors, the group authorship of the series. And then there are additional comments in the same issue, or the bound issue, as well as online. So these are the 4 papers to come, and you'll hear from the lead authors for each of those in a few moments. What I'm going to talk about, though, as I say, is paper 1 of the series, where we describe the prevalence of the conditions, the nutritional conditions, and their consequences. One thing we did, and it's presented in paper 1, but it's really an overarching framework for the entire series, is to redo somewhat a very traditional framework that had been used for a long time, first developed by UNICEF, and then we used it, actually modified slightly, in the previous series, which was really the determinants of undernutrition, or the determinants of stunting, if you will. We thought, for a variety of reasons, we should turn that around and say, what are the determinants of optimum fetal and child growth, but not only physical growth, but development as well. So very purposefully, we combined in this series both the physical and the mental emotional aspects of development. And that was drawing on work that came out in 2 previous Lancet series on child development, very important series in their own right. And this was our attempt to marry, if you will, the nutrition and developmental literature and interventions, because there is a great need and synergy if one does that. So the central part of this this framework is, in a way, the familiar determinants, where we have at this level what we're trying to achieve. We have at this level the immediate determinants, so breastfeeding, nutrient-rich foods, feeding and caregiving, low exposure to infectious disease. So these are the most immediate determinants related to optimal growth and development. And then we have a set of what we call nutrition-specific interventions to address that level. And you'll hear from Sophie Buta the nutrition-specific interventions that are listed here. We have in this row, in the determinants, the underlying determinants. So this is where you would see food security, caregiving environment, access to resources of various kinds, health services, for example. And this is where we say that the nutrition-sensitive approaches from other sectors can come in particularly strongly to have an effect. So this is where agriculture may affect food security. And we think of those programs or approaches affecting primarily the underlying determinants of growth and development. But then importantly, we have here the environment in which all of this takes place, the context, political context, social, political, leadership, governance issues, and that leads to the paper 4, which talks about the enabling environment to address nutrition, and what are the approaches that might be put in place both at national and global level. So as I say, this is our framework for the paper. Another aspect, though, is we've framed this a little more now in regard to the life course, and we look in the papers across the life course in relationship to the effects of nutritional conditions on morbidity, mortality in childhood, cognitive, motor, and socio-emotional development, school performance and learning capacity, adult stature, and obesity, and non-communicable diseases, as well as work capacity and productivity. So a life course is very important in the way we conceptualize this as well. And in fact, one aspect that we'll deal with here, which we didn't, is adolescent nutrition, an important aspect that we had not addressed very well in the previous series. So I'll begin to now show you some data that come from paper 1 of the series. This is in regard to adolescent nutrition, important for girls and for their offspring. As this shows, there's a very high rate of stunting in many of these countries, and the rates of low BMI are much lower, but stunting is quite high. And the rates of high BMI or overweight or obesity, not so high either, although coming up in Brazil and Guatemala. But overall, as many as half of all adolescent girls in some countries, actually in many countries, are stunted. This increases their risk of complications in pregnancy and in delivery with obstructed labor, and increases the problems of poor fetal growth, which we'll pay a lot of attention to in this series. So to go on to maternal nutrition, this shows the trends in the various UN regions of the world, trends in thinness. So the set of bars here is low BMI, and then the trends in overweight and obesity in women aged 20 to 29 years. So I think first you can see that if you take global, which is here, there's been perhaps a slight decline initially, then a plateauing of the reduction in thinness or low BMI. But overall, in the world and certainly in some regions, a very strong increase in high BMI or overweight and obesity in women. This is even true in some of the developing areas such as Africa, where you see an increase. So the prevalence of low BMI in adult women has decreased in Asia and Africa since 1980, but remains higher than 10%. And maternal overweight and obesity has increased steadily in virtually all regions, resulting in increased maternal morbidity and mortality related to the maternal overweight. I don't have time to present all the details, so I'll just give a few highlights of some of the micronutrient areas, the findings. Iron and calcium deficiencies particularly contribute to maternal deaths. We've redone some analysis related to anemia in pregnancy and the risk of maternal death. It's a very strong risk factor for maternal mortality. We think this most likely works through the risk of dying from hemorrhage, and hemorrhage is the most important cause of maternal deaths, accounting for 23% of all deaths. Calcium deficiency increases the risk of preeclampsia, which is currently the second leading cause of maternal deaths, 19% of total deaths. And so we think collectively addressing these two minerals and their deficiencies could result in a substantial reduction of maternal deaths. The evidence also that we looked at shows that short maternal stature may lead to obstructed labor and to both maternal and fetal complications, leading to either stillbirth or early neonatal death from obstructed labor, particularly if services are limited and cesarean section not available. Maternal stunting and low body mass index increases the risk of fetal growth restriction, and we use in this series being small for gestational age as the indicator. And maternal obesity, on the other hand, also has bad consequences, leading to gestational diabetes, preeclampsia, hemorrhage, additional risk of neonatal and infant death. So problems on both ends of the nutrition spectrum. There is in this series a set of new analyses done by Joanne Katz, who's here in the audience, on the risk of being born small for gestational age, the prevalence of small for gestational age births done by other colleagues of ours, and this was put together to get the deaths attributed to being small for gestational age. So in the various regions of the world, you see a quite high proportion, more than 25%, let's say, in Asia, of the births being small for gestational age. And overall, 27% of births, all births in low and middle income countries, are small for gestational age. That's 32 million babies born per year. When we look at the risk of mortality in a child born small for gestational age or preterm or both, what we see here is that if the baby is full term but small for gestational age, there's a 2 or 3-fold increase in the risk of death. Babies who are preterm but appropriate for gestational age have a 5 or so fold increase in the risk of death. Having both greatly increases, perhaps in an additive way, the risk of death. So the worst is being both preterm and small for gestational age. Now, the prevalence of these conditions, though, would be, this is a small fraction, and a term and small for gestational age is a large fraction of births. So the attributable burden would be very greatly in this category. So the reductions in child mortality might be expected if we can target interventions to reach babies who are born too small as well as too soon or premature. But in addition to the risk of mortality, for the surviving babies who are born with who are small for gestational age, we also see that they're at risk of stunting. So stunting at 24 months, stunted linear growth, actually has a much higher frequency in babies who are born small for gestational age. So if you take here small for gestational age but full term, they have more than double the rate of being stunted at 24 months of age, and high but with wide confidence intervals also for the combination of preterm and SGA. So in our attributable risk calculation, what we're able to say, combining the prevalence of the condition and the risk, is that 20% of stunting by 24 months of age could be attributed to being born small for gestational age. Again, emphasizing the need for interventions at the time of pregnancy or even before. Going on to child nutrition, we see that the rate of stunting, the prevalence of stunting, has been declining slowly in all regions of the world. The global decline is here, about 2% a year. And these are projections out, so we're about here. These are also projections out to 2025. And so you see where we might be. I'll just point out here while I'm on the global figure that the current World Health Assembly targets for 40% reduction in stunting would have the number be about 100 million at this time point, but in fact our current trends would project out to 127 million. So we have a ways to go to accelerate that decline in stunting. I think you can also see, though, the rates of decline in the prevalence have been highest in Asia, then in Latin America, but actually quite slow in sub-Saharan Africa. So not only are the rates slowly declining, or the prevalence rate slowly declining, we actually have an increase in the number because of population increase. So this is the only part of the world where the number of children who are stunted is actually increasing. So overall for the world, we say that there's 165 million children under 5 who are stunted, 26% of all children. And as I said, about a 2% annual rate of reduction, which is not fast enough to reach the World Health Assembly target. We also look at the prevalence of wasting, and the prevalence is still too high for wasting, shown in the light bars, or severe wasting, shown in the darker blue. And this, in fact, is not declining either as much as we would like. So 52 million children under 5 currently with wasting, 19 million severely wasted. Now, looking at the flip side of this, we also look at child obesity, and where is this going? So the uncertainty bars are quite large because it's harder to predict the future with some of these, but if you look at the global figures, you can certainly see an upswing in the predicted prevalence of obesity in children, and going up to prevalence of around 10%. But we're less certain about Africa, but certainly an appearance of an increase in obesity, and really no question about, Africa is here, no question about a trend going up in obesity. And on to micronutrient deficiencies. Deficiencies of the essential vitamins and minerals continue to be very widespread. They have adverse effects on child survival and development, and they have bad effects on maternal health as well. We single out vitamin A and zinc deficiencies because they adversely affect child health, morbidity, and mortality. And deficiencies of iodine and iron, together with stunting, we think they contribute to children not reaching their developmental potential. We have in the world significant progress in regard to vitamin A, and so our estimates of the attributable burden are much lower than they might be without the program. So the current coverage levels of vitamin A supplementation are rather high, not universal yet, and still some ways to go with that. But clearly we can't afford backsliding in this because the dietary intake of vitamin A in many countries is still inadequate, and the supplementation is still needed. when we talk about the deaths attributed to nutrition, we have to be very clear. We're talking about an interaction between nutrition, undernutrition, and infectious diseases. And so what we call the synergy of the interaction between these two really results in the attributable deaths. This is just showing some new analyses, redone analyses related to the risk of death, the hazard ratios. I'm only showing stunting here, similar numbers for underweight or wasting. In fact, the wasting numbers, the risk are even higher. But if you take, for example, the children who are -3 to -2 z-score length or height for age, their elevated risk of death is more than double. If you take -3 for all causes, it's more than 5 times risk of death. And you can see it here for the individual causes. Let's say pneumonia, where there's significant elevation, diarrhea, measles. So these major causes of death are the ones, in particular, these infectious causes, where the synergy of nutrition and infection results in the excess deaths. So this is where we do the calculations related to the attributable deaths to undernutrition. I wanted to show this quickly because it shows the great disparity, inequity in stunting in regard to wealth quintiles. So on the x-axis are countries. If you have a telescope, you can read them. They're in the paper. I think they're readable. But it basically says that the poorest quintile have much higher rates of stunting than the wealthiest quintile within each country. There are notably few countries, but one I would single out way down at the bottom here that is a remarkable story. That is Brazil, which has not only achieved in recent years a very large reduction in stunting, but has essentially eliminated its inequity. It used to have a very large gap between rich and poor in the prevalence of stunting, and through very concerted, very wide national programs, it has essentially eliminated both stunting and the disparity in stunting. Yet many other countries continue to have that disparity. The top panel is an interesting one because this is overweight, and what you can see is virtually no pattern. In some countries, the wealthiest quintile has a little more overweight, as you might expect, but in some countries, it's the lowest quintile. So not very much disparity in the patterns of overweight at this point. Breastfeeding practices, we looked at again, analyzing survey data, still inadequate, suboptimal in regard to the recommendations of exclusive breastfeeding for the first 6 months and then continued breastfeeding for at least the next 18 months. So you can see the patterns here by by region. There's another aspect we do look at in terms of the prevalence, early initiation of breastfeeding within 1 hour, which is recommended. Still not as high as it should be, only 50% or so. So there's tremendous importance to the breastfeeding practices, and what we would have to say, though, is they're still inadequate and need more attention. Exclusive breastfeeding is only at about 30% for the first 6 months of life in all of the major UN regions. We have done this calculation of the deaths attributed to each of these nutritional conditions, and this is for the individual ones. So fetal growth restriction, as indicated by small for gestational age, more than 800,000 deaths. Stunting, 1 million deaths per year, I'm talking about. And then you can go down here, but really it's important not only to look at these individually, because you do get some sense of their importance, but we also, because they do overlap, have to look at the joint distribution. So by some statistical wizardry, we can actually look at all of these at the same time. That will enable us to not overcount, double count the conditions. And what that does is it allows us to say that if you do look at all of these together, that includes fetal growth restriction, suboptimal breastfeeding, stunting, wasting, and vitamin A and zinc deficiencies, because those two vitamin and mineral deficiencies are the ones that are associated with excess deaths. we then come up with about 3 million deaths per year attributed to these nutritional conditions, about 45% of all under 5 deaths at this point. Importantly, a large fraction of those would be just in related to the 2 interventions, particularly that affect the neonatal period, fetal growth restriction, and suboptimal breastfeeding. So overall, as I say, 45% of all under 5 deaths attributed to undernutrition, 3 of the 6.9 million deaths for 2011, and fetal growth restriction, suboptimal breastfeeding together are responsible for more than 1 million deaths. Deficiencies of vitamin A and zinc for about 300,000 deaths between them. So finally, to end on the key messages, I would say short stature, low BMI, vitamin and mineral deficiencies in pregnancy contribute to maternal morbidity and mortality, contribute also to fetal growth restriction, infant mortality, and stunted growth and development of the child. Stunting of growth in the first 2 years of life affects 165 million children who have an elevated risk of mortality. They have cognitive deficits and increased risk of adult obesity and non-communicable diseases. And I don't have time to go into the details on that, but we do talk about the common origins of the consequences of undernutrition, but also the longer-term effects on overweight, obesity, and NCDs. And there is a companion paper with this series from Linda Adair that talked from the cohorts group that talks about long-term consequences that fit with this conceptualization. And finally, this new evidence strengthens the case for the focus on the critical 1,000 days, the window of pregnancy and the first 2 years of life, highlighting even more the importance of early interventions in pregnancy and also adolescent nutrition, because at the time of conception and early pregnancy, even before pregnancy is recognized, nutrition is important, and one can only address that by having better nutrition for adolescent girls. And I would end with that. Thank you very much.